We will go on with the next presentation from Serbia. Anna Krivokuća, doctor from the Institute of Oncology and Radiology in Serbia, who will take even one more step further in the pre-diagnostic testing, and she will deliver a talk about genetics, genetic testing and genetic counseling in breast cancer patients. Thank you so much for your presentation, Dr. Krivokuća.
Good afternoon. Thank you for having me today with you. I come from the Institute for Oncology and Radiology of Serbia, and I'm head of genetic counseling for hereditary cancers department. And today I'm going to speak about the importance of genetic testing and genetic counseling in breast cancer. As geneticists, when we talk about deciding what kind of tests should we perform, we always think about the time of genetic change. We need to know when the genetic change happened and whether that information is important for us or not. And when we speak about hereditary cancers, especially hereditary breast cancer, we usually take tests for germline mutations. These mutations are present in germline, and all cells of an adult carry the mutation. Mutations can be inherited from parents, and additional mutations might be found in tumors. A large number of affected family members always indicate the importance and the need for germline genetic testing, and sometimes people who carry these mutations, they come from families with rare, multiple, and early cancers. And when we speak about hereditary breast cancer genetic testing, we usually talk about BRCA genes in breast cancer. And we are all aware of the importance of these two genes in hereditary breast and ovarian cancer. However, we might think of different approaches, since we now know that these genes are not the only ones important in defining hereditary predisposition. BRCA1 and BRCA2 are high-risk breast cancer genes, and they carry high risks of breast cancer in women and men, ovarian cancer in women, pancreatic cancer in men and women, and prostate cancer in men. So when we speak about high risks, we speak about 70 to 80% of lifetime risk of having breast cancer, for example, in BRCA1 carriers. And when we speak about risk for ovarian cancer, it's a bit lower, but it's still important. It's up to 50% for women and for BRCA1 carriers, and up to 20% for BRCA2 carriers. Risks for pancreatic and prostate cancers are lower, but they are still significant. And why are these mutations and these genetic tests so important? Because they have multiple implications, not just for breast cancer patients and cancer patients overall, but for family members and healthy carriers as well. So in healthy carriers, we may perform risk estimations, and we may actually see what are the lifetime risks of developing certain type of cancers. In those that are already developing cancer, we can estimate possible risk of another new cancer. We also talk about risks to other family members. We also talk about prognosis and therapy options for mutation carriers. In healthy populations, we talk about importance of screening. And for those that carry BRCA1 and BRCA2 mutations, we might consider starting earlier in life. We might consider more aggressive approaches more often, and we might want to enable early detection and to catch the disease in early phase when it's most curable. Also, we might think of prevention in terms of medication, risk-reducing mastectomy or oophorectomy, depending on the type of the mutation, on the gene, and on the family history of the patient. And for many, many years, for many, many decades, I may say now, we perform germline genetic testing in those patients that have high risk of carrying mutations, which are patients that come from high risk families and who have many affected family members. And in hereditary breast cancer, we now know that we might expect up to 20% of BRCA1 and BRCA2 mutations. However, new treatments have emerged, and now we talk about PARP inhibition treatment, where we need to find those BRCA carriers no matter whether they have family history or not. So we think of testing in sporadic cancers as well, and we think of new indications and new programs for testing, not just in breast cancer, but in ovarian cancer as well. And we'll look for BRCA1 and BRCA2 germline mutations to tailor treatments and to apply new therapies. And now we come to two models for genetic testing in breast cancer. The one is from the hereditary cancer point of view, when we look for mutations in BRCA1 and BRCA2 and other genes, of course, in people who have a high burden of cancers in their families. Other and new approaches have emerged. One of these is looking for germline BRCA1 and BRCA2 mutations in patients who might be candidates for PARP inhibition treatment. So we'll look for the same thing, but from the different angles and from the different point of view, but the tests that we perform are more or less identical. And I've been speaking about other genes that are really important besides BRCA1 and BRCA2, and now we know about polygenic model of inheritance for hereditary breast and ovarian cancers. And of course, we've expanded our testing and we now talk about polygenic model and gene panels for hereditary breast and ovarian cancers, since BRCA1 and BRCA2 are not enough to explain the whole hereditary predisposition. And we have a lot of guidelines that we follow. These are NCCN guidelines that are updated twice or 3 times per year. We also follow European Society of Medical Oncology guidelines. So we have the newest ones from 2023 and 2024. They say that the germline testing and subsequent genetic counseling for pathogenic variants in BRCA1 and BRCA2 should be offered to all patients who meet the respective national criteria for hereditary disease and to those who are candidates for adjuvant olaparib therapy. And also, we have to think that those people with significant family history should be offered genetic testing not just for BRCA1 and BRCA2, but should be offered multi-gene panels of clinically validated ABOC genes. And how do we do genetic testing in hereditary breast cancer and sporadic cancer when we look for germline mutations? We perform NGS, and it has become a gold standard for searching for mutations in gene panels. When we look for germline mutation, it's usually blood or saliva. We perform DNA isolation, we analyze quality and quantity of DNA, and then we perform library preps with different kinds of protocols and massively parallel sequencing. We perform primary, secondary analysis, and then we come to variant annotation. I think this is the crucial point, because when we find variants, we need to annotate them and to find those that are clinically important and that are actually pathogenic or likely pathogenic. And how do we do that? We classify them in one of 5 classes, 1 and 2 being benign or likely benign, and they do not go into the report. Class 4 and class 5 are likely pathogenic and pathogenic mutations, which are actually clinically actionable and which are most important for our clinicians. And we have a gray zone of class 3, which are mostly missense mutations, and they're of uncertain clinical significance, which are tricky to deal with, but they are usually written in the report, but they have to be reclassified periodically, so we can either put them in benign or likely benign group or upgrade their importance and alert clinicians about the change of their class. And that being said, we have a couple of possible outcomes of germline genetic testing in hereditary breast cancer. We have positive results when we have detected mutations that are likely pathogenic or pathogenic. And these are, let's say, the easiest ones because we know clear clinical significance of these mutations and we have clear recommendations for clinical management for mutation carriers. Then we have negative results when we have not detected mutations that are class 4 or class 5. However, we have to be really careful because there are sometimes limitations of these tests. We have to think about additional genetic factors. We need to think about additional tests, or we sometimes may have missed proper annotation. So we have to be really careful. And even if we have negative results in the patient who already has a high burden of cancers in the family, it is recommended the clinical care should be based on the family history. And sometimes these patients are still considered high risk patients. And these are unclear results that are actually results when we find the class 3 variant. These variants of unknown clinical significance, and these are more frequent in panel testing when we have more genes and more variants to annotate. They are not clinically actionable at the moment, but they are usually written in the report, and we have to do the follow-up on their status. And again, clinicians should take care of the patients based on their personal and family history and be in continued link with the lab. So when something happened, when they downgrade or upgrade the classification of these class 3, they should know right about everything about it. And this is like a graphical overview of what should we do when we identify inherited pathogenic or likely pathogenic variant. So we have class 4 or class 5 in our panel. We are able to define breast and other cancer risks, if you remember from the first slides, for those that are healthy and for those that are already developed cancer. For those that are healthy, we can offer early detection and risk reduction strategies. For those that have cancer, we can offer targeted therapies. And also, which is really, really important, we should offer the testing for family members. We should perform detailed pedigree analysis, and we should think of how to manage healthy mutation carriers. And then we come to genetic counseling. In the whole process of genetic testing, I think, and I usually say that the easiest thing nowadays to do is to perform a genetic test. It has become more affordable, and we now often see a lot of different DTC companies that offer all kinds of genetic tests that you can pay out of your pocket. However, it is really not recommended to do that because without proper guidance from the genetic counselor, it's difficult to interpret these tests and to actually use them in your life. So in the most important part of the genetic testing is actually having someone from the genetics team who can explain to you what the test is about and what are you going to do with the results of the test. And that is why the genetic counseling is so important. So when we perform testing for germline analysis, we offer pre-test interview where we talk with the patients, where we discuss their personal medical history, where we discuss family history, where we draw pedigrees, where we analyze the family tree, where we determine the pattern of disease inheritance, and when we at the end eventually decide what kind of test is the most important and the most appropriate, because we do not offer something that is not clinically meaningful for that particular patient. You can do whatever you want by yourself, but we are going to offer the gene panel that can be clinically applied in the situation and in the specific case of patient and his or her family history. And we offer, of course, information on the type of the test, on the waiting time for the results. We give the information on possible consequences and potential outcomes. So we explain everything. And eventually, if the patient agrees to testing, we have informed consent that should be signed. After the analysis is done, we call patients to come back to post-test genetic counseling, where we communicate the results with them. Then we explain the type of the detected genetic change and its implications, and it's always difficult to explain these class 3 variants, so they have a lot of questions that we have to answer to. And if needed, we perform analysis of the family tree, which is deeper, so we identify additional family members that should be tested, and we give the recommendations for family members. And of course, we wait for them to come back with their families to see who should be tested at what point of time. And the collecting family history information is crucial here. So we need minimum of 3 generations. So we are able to identify families who would benefit from genetic services, and actually patients or individuals. And the thing is, genetic information is really tricky to handle, germline especially, because it's not just information about the patient, but about the family members as well. So we need to be considering sensitivity, privacy, and confidentiality of genetic information. But I think that drawing family history tree and giving appropriate information to your healthcare provider is really important. But it's difficult. It has a lot of challenges, especially because many countries lack trained genetic counselors. We have incomplete family histories. There are issues with type of tests, the insurance, the costs, the management of healthy individuals who are mutation carriers. Some countries do not have practices for dealing with healthy mutation carriers that need screening or prevention. Then there is the issue about non-informative results, interpretation of the results, these class 3 variants, again, a psychological burden. So there are a lot of challenges, but it's always best to have someone to talk to from the genetics team. Even if you are a healthcare provider or oncologist, just have someone online to answer some of the tricky questions. And I just wanted to point out that genetic counseling is really important, but there is a huge gap between the needs and the actual availability of genetic counseling. This is the study from University of Michigan. It was in 2017, but it was not that long ago. Most patients, and it was done on women aged 20 through 79 diagnosed with breast cancer, and they were surveyed about how much they wanted genetic testing and whether patients talked about genetic testing with any healthcare professional. And interestingly, most patients reporting wanting genetic testing, but only up to 30% reported having it. Only 40% of all high-risk women and 62% of tested high-risk women reported having a genetic counseling session, which leaves a huge gap of those that are in need of genetic counseling, but they couldn't afford it for one reason or another. And the thing is that we miss opportunity to prevent cancers if we do not offer adequate genetic counseling and offer adequate genetic testing, and of course follow up and clinical management later on. And if you see this photo, this is just for the end. I just wanted to remind you that in 2007 we had $1 million that we needed to give out for sequencing of the human genome. And let's say 10 to 15 years later, we can sequence our genome in less than $1,000. So these tests are now really affordable. But as I said before, without proper genetic counseling, please do not choose anything, and because I think that the risks are higher than the benefits that you are going to achieve with the testing. And to just remind you, the germline genetic information is specific because it has the shared nature. It's not just ours, it's also the information about our family members. It has identifying nature, it has probabilistic nature, and it is permanent. So we have to be really careful when we deal with germline genetic information. And with this, I would like to conclude and to thank you for your attention. And of course, I'm here for any questions.
Thank you, Anna, for this excellent presentation. And we hope to organize this meeting in person. I'm really excited to have all the presenters in one place to have deeper discussions on all these very important topics in oncology and also screening. The Central and Eastern European Academy of Oncology is going to establish a team of international experts to form a virtual oncological tumor board to give free advice to all the countries and patients in these 22 countries when it's coming to oncological decision makings and further treatments, to guide them in molecular testing and genetic screening and specific questions they might have.